in Ophthalmology. Dr. Mandeep Singh is designated as Senior Vice President, Quality and Clinical Operations, Center for Sight, New Delhi. He is also involved with the DNB program at Center for the Sight, spearheading the NABH accreditation initiative across various locations of Center for Sight, have successfully achieved NABH accreditation at 15 of the group hospital, re-accreditation at 5 of the group hospital, entry level at 15, and renewal of entry level certification at 7 of the group hospital. Dr. Mandeep Singh, sir, now over to you.
Thank you for the kind introduction. I also thank CAHO and the organizing committee for giving me this opportunity. When we're talking about indicators, what NABH guidebook simply states that it is a statistical measure of performance of the functions, systems, and processes over time. So that is a very simple and very crisp definition, makes it very simple to understand, because often people are asking what indicators do we need, what are the indicators and all these things. So irrespective of which standards your hospital is going for, whether it is HCO, SSCO, entry level or ECO, you will find in chapter 6 that the standard states that the organization identifies key indicators to monitor the structures, processes, and outcomes which are used as tools for continual improvement. So basically, there are 4 aspects that are covered in the standards. The indicators need to cover the clinical areas, the infection control, the managerial areas, and the patient safety aspects. So what do you mean by structure, process, and outcome? Like when we are talking about structure indicators, they are basically attributes of the setting in which the care is being provided. It is a measure of the hospital's capacity to provide a good quality care. And when we talk about processes, they are referring to the activities of the caregivers, the various clinical and paraclinical team, that the activities that they are doing. And they are generally reflecting of the recommendations for clinical practice. And when we are looking at the outcome, these indicators are indicators of the change in the health status of the patient. So the question comes, what is the valid indicator? I got a message earlier from one of my quality managers, why should a particular indicator be selected and why is it mandatory, why should not? So these are some questions that arose. So a valid indicator, basically, I'm just giving you here an example. So structure would be like the various equipment, manpower or consumables or processes, trainings, whatever you are putting into a system. And the system, the process which goes on, like pre-surgery workups, the biometry, the LASIK workups, and then the surgery itself. And the outcome would be the post-surgery vision or the other desired patient health status change. So when you are looking at the indicator, you need to ask whether this structure indicator is likely to improve the process or improve the outcome. And similarly, for a process indicator, you need to ask the question whether this process indicator will help me to improve the outcome. And for an outcome indicator, you need to ask whether it is representing the desired outcome. So once you get these questions, once you know that this indicator is going to help me in this answer this question, then you have more or less selected a good valid indicator. So when you are looking at an indicator, I will be covering the 4 aspects, the identification of key indicators, the data that we need, the root cause analysis and corrective actions, and how to monitor and review. So first thing is identification of key indicators. So do not measure everything. That is a simple dictum. Like, it's not that you keep on measuring each and everything. You need to identify the key. So what do you mean by key indicators? They should be the ones where you focus on the important improvement projects, which are going to have the most significant impact on the working of the hospital. And we should be able to have an accurate and reliable data, and also be able to compare between facilities and compare over time. So these are the indicators that you need to decide on. And then the staff should also be able to relate these indicators to their daily work and be able to implement in quality improvement projects. So NABH guidebook on eye care standards has given the mandatory indicators. So like, for example, appropriate patient assessment, they mentioned that the time for initial assessment in OPD and emergency is a mandatory indicator. A number of reporting errors, number of percentages of redos in diagnostic services, medication errors, percentages of adverse drug reactions, percentages of modification of anesthesia plan, anesthesia adverse events, unplanned return to the OT, rescheduling of the surgery, and percentage of cases where the process for ensuring that there is no wrong surgery, wrong procedure done, how much adherence has there been. Also bed occupancy rates and average length of stay. Usually for most of us it may be not applicable because we are daycare, but there are many big organizations in eye care only where patients are staying overnight, so maybe that's applicable there. OT utilization rates, the downtime of critical equipment, patient satisfaction, waiting times, employee satisfaction, including attrition and absenteeism, and employees who are aware of their rights and responsibilities. And then the various adverse events, the near misses, the sentinel events, the medical records completeness, particularly the availability and completeness of discharge summary, and the consent. So these are the mandatory indicators. You can have any number of indicators, but you need to, when you are implementing these standards, you need to cover them. So accordingly, like at Center for Sight, we have listed out 20 odd indicators which we are covering, trying to cover all the mandatory indicators. So when you come to data, you need to think of the quality of the data. So you need to identify what data is needed, what would be the source from where you will get the data, what would be the format in which the data should be collected, who will be doing it, because it should not be only the job of the quality manager, because the person who's actually doing the work is generating the data. That is the person who's key for ensuring that it is a valid data, it is a correct data, and not data which is unreliable and resulting in a wrong calculation of the indicators. And the periodicity, whether you need it daily, you need it weekly, you need it monthly, that is you have to define. And the quality team needs to verify and validate randomly, maybe intermittently, whether the data that is being generated is valid and verified. So on a daily basis, various hospital functions generate many documents like emails, registers, duty rosters, OPD, OT schedulers, incident reports, various transactional reports like number of OPD, number of OT, and all these things, they can all be the source of data. But you need to decide whether you need to create a new mechanism to capture the data, or the present format in which the data is being generated, is that sufficient for you? Also take along the end stakeholders, the people who are doing it, because it should not be interpreted as an unnecessary new paperwork, because sometimes the staff spends time in the paperwork of collecting data rather than actually benefiting from the data. So can you make it easier? So at Center for Sight, we have been fortunate that our quality team and also the IT team have started utilizing online forms and softwares. And these are not something that we purchased from some vendor. They simply created their own. Like you generate Google Forms or Outlook forms. Because we are using Outlook as the official email ID, so we preferred that one. But we have done it this way. So what benefit it gets is that I'm able to do the audits, I'm able to generate the Excel sheets and also the various graphs and charts on my mobile phone. The screen that I'm showing right now, they are all screenshots from my own mobile phone, like it's the hand hygiene checklist, the audit hand hygiene, and then the outcome. So just trying to make it simpler and faster and more convenient, rather than the nurse carrying a pen and paper, taking a round, she just simply fills the form on her mobile phone and submits. That's it. So she doesn't have to come back and then type it out in an Excel sheet and do these things. So when you talk about the benchmarks and alerts, so what is benchmarking? So basically it is a comparison with the best to know where you stand. So it can be an internal benchmarking of comparison of practices within the organization, between clinical departments, between or it can be between the various branches of the hospital. It can be a comparison over time, like how you have performed over the past and how you're performing now. Or it can be also an external benchmarking where you're picking up from the best in the competition and best in the fraternity, and see where things have helped others to improve and how you stand against that. You can. So I'm just giving you examples here, like a recent systemic literature review published very recently has definitely found a very positive association between benchmarking and quality improvement. So like we use like industry benchmark for net promoter score, and we use similarly an industry benchmark for employee attrition rate. Or we can also look at our past performances and determine that we need to ensure that we reach a certain level, and that is how we have decided that we need to reduce our rescheduling rates of surgery to less than 5%, or a repeat visual test to less than 5%. Or what is the ideal situation? You can say a medical record has to be 100% complete. So this is an ideal situation. You can't judge on past or something like that. Similarly, we can determine that we need to ensure that there is no prescription error in spectacle. So ensure 0. So these are the ideal situations. And you can also go by published literature, like incidence of PC rent, or the agreement between the clinical diagnosis and histopathological diagnosis in case of retinoblastoma. These are all examples that I'm giving from Center for Sight. So you can choose from where you want to do your benchmarking. So I'm just giving an example. So again, in one particular instance, even though the benchmark was less than 5% for repeat vision tests, we found an increasing trend over 3 months, and a red flag was raised, and an RCA kappa was done, and we found that because there was an increased prescription of test, and under pressure to finish the test within time, the technician may not have properly guided the patient, counsel the patient, or pause, and then it was a vicious cycle, more mistakes, and the doctors were telling them to repeat the test, and then the increase in number of tests was happening. And so once we did the training, we talked to the optometrist concerned, there was a definite big improvement, and we were able to almost touch the benchmark level over the next 3 months. Similarly, there was a patient dissatisfaction. The net promoter score started dipping, and when we did an analysis, we found that there's a problem with the streamlining of the appointment process. And then when it was done, there was a good recovery in the patient satisfaction score. Another example is like there was a few new staff had joined at the billing counter, and then bill mistakes and cancellations were happening frequently because they were not very familiar with the ophthalmology terms and all. So a repeat training was done, and we were able to bring it down. Another example is a recent one where some anterior chamber reactions were being reported, and when we narrowed that down, we realized that we need to change the viscoelastic, and when we were able to bring it back to 0. So these are certain examples. When you raise a red flag, you know your benchmarks are being breached, and you know how to do an analysis and find answers to it. So are you getting zeros or hundreds? That means, is there no scope for improvement? Like, for example, modification of anesthesia plan, persistently 0. for a certain number of months. So have you achieved the ideal situation? So for example,
so sorry to interrupt you. Just I wanted to remind you that we're running out of time.
Okay, fine. So this is an example where we were looking at autorefractors, we were getting zeros, but when we started checking the spectacle complaints, we actually had some data. So we need to review that. Similarly, we were getting patient times as persistently around 1 hour, but there were complaints and we added to optometrists, but we reviewed the data in another form as to patients getting prescription after 2 hours. And we realized we are actually improving from 12% to 6%, where we were able to give it faster. The prescription was given faster. So when you are reviewing, you need to measure what you want to have the indicators, and then the benchmarks you can review the data collection tools, and are you collecting the right data, you need to verify. So these are the things that you need to review. So thank you for patient listening.
Thank you, Dr. Mandeep Singh.